Okay, so we'll carry on where we left off yesterday. Ahmed, what do you think of this case?
Yesterday.
Last 2 weeks ago, figuratively speaking.
So it's like lots of changes.
It's like yesterday.
It's like the genetic changes of TMJ.
Okay, so we've got on the coronal images, we have a lot of irregularity of the subchondral bone. What about the sagittal images? How are you going to describe it?
It's cartilage loss, I think, and some subchondral cystic change, osteophytes.
Okay, and a big anterior osteophyte. And what about the disc?
Disc is gone, I think.
Yeah, it's hard to see. This may be the disc right in through here.
Right.
Okay, so this is the coronal T1 and the sagittal T2. So what about the closed and open mouth views?
So the disc. The disc is.
So in these, we really don't see a disc. So the disc looks like it's gone
Right.
and been resorbed. What else do you see here?
They say it like a severe degenerative stuff, some venous formation or something.
Okay, well, so in the closed mouth view, what's the position? What's the position in the open mouth view?
The condyle, kind of forgot.
Okay, so so here we can see that the condyle is very degenerated. The arcuate eminence here is not smooth like it was before. It's distorted. We can see that, that in the closed mouth view, the condyle is really in the fossa here. In the open mouth view, though, we have very little translation and very little rotation of the head. So there is marked limitation of motion, and it looks like the disc is degenerated and gone, and we have all the degenerative disease that you talked about. So this is chronic.
That's a large osteophyte, isn't it?
Yes, it is. Yep. By the way, when I was in Montreal, I heard a lecture on temporomandibular joint, and they said that 11% of the world population have significant problems with their temporomandibular joints. Okay. Next case.
Okay, 66-year-old woman with left greater than right TMJ pain. Teeth vibrate with certain words, crunchy feeling. So, closed. I think I'm seeing, this is a sagittal view?
Yes.
Okay, I'm not sure where the condyle is. Is that
Here's the condyle.
Okay, that's the condyle. Okay, so the disc, I'm not seeing all that well there. I don't think
Okay, I don't really see much of a disc. See a lot of eburnation
a lot of urination
on the arcuate eminence, the fossa, as
And the
well as
condyle.
the condyle.
Right.
And if we go to the open mouth position,
Okay, in the open mouth position, it looks like I don't see the disc again. It looks totally degenerated. It looks like there's anterior translation, which is normal, and that we have an arrow pointing to maybe a loose body.
okay, there's a,
Okay,
I think that's a gradient echo.
and that is in the closed position again, I guess.
Yeah.
Okay, and there's a loose body there. I see, sort of anteriorly.
Okay.
Again, there on the CT, it looks like there's a loose body.
There are the osteophytes there. Okay. So what's going on here?
So I think there's severe degeneration and
Okay.
loose body sort of
So you have a
floating
little
around.
subchondral cystic changes, probably an osteophyte formation, a loose body anteriorly here in the closed mouth position.
Mhm.
We have eburnation and complete absence of the disc here, which is probably degenerated. When you open mouth view, you have some rotation and some translation, probably a little bit less than normal in this case, and we see anterior displacement of the loose body that we talked about.
Mhm.
And the gradient echo just shows loss here and then the CT scan shows the loose body. So it's just further degenerative findings that you can see in degenerative disease of the temporomandibular joint and maybe a cause of crunching, right?
Okay, here we have looks like two sagittal views. Not sure if one is an open position or closed. This is the GRE, I guess.
Yeah, I think this is the closed and this is the open, though it's not labeled here.
So there's no much translation in the open view. There's some aberration, maybe an osteophyte anteriorly in the condyle.
Right. And certainly that abnormal arcuate eminence as well.
Arcuate eminence, yeah. Okay, so that's.
Now, some people use the term AVN of the condyle or this area. I don't like to use that term because I don't know that there's been anyone who've actually shown that the disease here is primarily due to bone infarct. I think this is all degenerative disease, and some people just use the term AVN when they see severe degenerative disease, and I don't think that's appropriate.
Sorry, the hyperintensity in the arcuate eminence, is that, or is that soft tissue more anteriorly?
Here?
Yeah, all
that's soft tissue.
That's soft tissue.
Yes.
And the disc is gone.
And the disc is gone, right.
A lot of irregularity, probably some subcondylar cysts at the TMJ.
Okay, so first start out talking about the condyle. What do you see in the condyle?
I know the articular surface is very irregular, probably with some cyst formation.
Okay, for a little anterior osteophyte, and then the disc.
I'm not sure I see a disc here at all.
Yeah, probably this is a deformed anteriorly displaced disc, and the arcuate eminence.
It's flattened, degenerated.
Yeah, flattened and very abnormal and very eburnated. This is the open mouth position, and the the head is right about here, and this is probably the deformed disc. This is a little cut over it. Notice again we have the marked deformity and eburnation of the arcuate eminence, and this is just more severe degenerative disease with destruction of the condyle. So, Har, what do you think of this case?
Okay, so are these open and closed mouth views?
This is coronal, and this is a closed mouth sagittal T1.
Okay, so on the coronal, it seems that there is degenerative changes of the coronary process, some bony remodeling. I don't see the disc.
Okay.
On the sag, what is it? Is it the disc that's displaced? I'm not sure what it is.
This is the arcuate eminence here, and we see chondrocystic changes here in the arcuate eminence. And this is probably a degenerated anteriorly displaced disc in this area, right in through here.
Okay.
So this is an erosion of the arcuate eminence, and this can either be due to degenerative changes, or you can see this in rheumatoid arthritis of the temporomandibular joint.
Okay.
Disc on the coronal view? Is it usually
No. The disc is hard to see if it's in the normal position on the coronal plane. If it's medially or laterally displaced, then you can see the coronal plane. Okay. Thomas, what do you think of this one?
So two sagittal views, looks like a T1 and a T2, and the condyles deformed, flattened, degenerative, and I'm not seeing a normal disc.
Yeah, this is a very deformed disc. It's anteriorly displaced. Abnormal contour of the arcuate eminence.
Right.
And then this is funny kind of stuff in through here, which is kind of intermediate on T1 and low on T2. This turned out to be a patient with rheumatoid arthritis, and this was all synovitis and erosive disease of the condylar head.
Okay, so 43-year female with jaw pain. So sagittal views, condyle, say the condyle irregularity, and the disc.
What about the signal in it?
Yeah. It's kind of erosion. The condyle, I think.
Well, we see loss of the normal fat signal. Deformity, probably an anterior osteophyte. We really don't see the meniscus here. Okay, this is closed mouth and open mouth. We see very little rotation in translation.
Right. So
here's the coronal and the T2.
Right in the coronal T2 is the signal of the condyle. Some irregularities, and so probably.
So the contour is abnormal.
Right.
You can see the anterior osteophyte here, a little bit of a fusion in the joint space.
So in degenerative.
Let me just see. Let's go back. This is 8601. 8601. This is 102209.
Is
Let's go back again. There's 8601.
right.
102209. Okay, if we go back here, you can see kind of almost a normal contour of the arcuate eminence,
Right.
but a very abnormal head with osteophyte, flattened, and abnormal signal intensity within the head. Very poor translation in the open mouth
Right.
view. And then if we go a few years later, we can see that there's much more deformity of the condylar head, and now a significant deformity of the arcuate eminence, which now has this kind of peaked appearance that we've seen in severe long-standing degenerative disease, rather than the nice smooth contour of a normal arcuate eminence. So this is severe long-standing degenerative disease. Now here's a coronal image showing more deformity of the head, and here's the T2-weighted image showing a lot of fluid in around the joint space there. And this is another patient with long-standing rheumatoid arthritis and destruction of the condylar heads.
So even with osteophyte formation, it could be RA, or there is it's like a reaction to the synovitis.
Well, what happens is you get destruction of the joint space, and then you develop degenerative changes. And it's the RA that that destroys the cartilage, which then starts the degenerative process. Mm-hmm. So a lot of reasons why you need to make the diagnosis of inflammatory disease early and treat it properly.
Okay, it looks like a couple sagittal T1 images, and the condyle looks like there's an erosion. And the condyle looks sort of concave, and there's a bunch of T1 hypointense soft tissue in there.
Abnormal disc there. Okay, and then here are the coronal images, coronal image and sagittal.
Yeah, the sagittal T2 image shows similar findings.
Yeah, and then here this is actually the disc, which is more medially displaced, and we're just catching some of the disc in here, and this was a congenital malformation of the condyle.
So that's not erosion?
That's not an erosion, actually. That was actually congenital. And you can, it's hard to see, but really look, if you follow that area, this is this concave here in the coronal plane, you can see that the cortex is still intact.
Right jaw pain after acute trauma. So this is a CT, like sagittal images. There's no translation on the open view. Oh, sorry, this is right on left. So
this is the symptomatic side. This is the asymptomatic side.
Right side. Okay. I assume this is closed, and it looks like there's narrowing of the space on the right side compared to the left. I wonder if there's some. Maybe the disc is displaced, or
the disc would be up here. And it makes you wonder if there's a problem with the disc because the bones are almost touching here. But this patient, let's just say this patient was a boxer and now has jaw pain.
Right jaw pain.
What would you look for?
Fractures first, and I guess the auditory canal. Yeah, there's some lines.
So that's an impacted fracture.
That's the first thing that came to my mind.
Yeah. That's because you're an old boxer, John.
It's true.
I'm an old one, all right.
So that's the external auditory canal. And you can see how close they are there. And so you can see how vulnerable.
Not only that, but it's an old fracture.
Okay. I don't remember the timing here. Okay. Here's a CT scan.
So there's an axial view of temporal bones, and it was right pain. So it looks like, yeah, there is a fracture there, line.
Yeah, the head wasn't quite straight, so they're not the same level on both sides.
Now it doesn't look old. Sure looked early.
Okay.
I don't know if there's an underlying congenital abnormality here. The mandibular condyle isn't even articulating really out. These are coronal views, right?
This? No, this is sagittal.
Oh, it's a sagittal. Okay.
There's a disc. There's the condyle.
This is open mouth.
This is the. I don't know whether this is open or not.
Okay, if it's closed, it's definitely abnormal with the anterior dislocation of the condyle and the disc. But even if it were, it must. Maybe the one on the right is open. Our right is opening. Oh, it's okay.
Come down here. There's a fracture.
Oh, okay, nice.
That's hard to see. It's hard to see that.
Yeah.
Well, there's so much abnormality here, but sometimes the biggest things are the easiest to miss.
So the D would help if we're a T2 or something.
Yeah.
Yeah.
Okay. Sahar.
Okay, looking at your female with pain and flooding of right TMJ. You see multiple areas of ossification around the right TMJ joint. Looks like it's a synovial pseudoneuromatosis to me.
Okay, good. Thomas.
Prior surgery for chronic pain. So the condyle looks abnormal morphology, and one of the is that post-surgical change of the condyle. Maybe? So the disc is in place.
T2. There's the T1, both closed mouth. There's the coronal. Yeah, and this is a Mitek suture in the condyle after surgery.
Okay.
So this was a paper back in 2013 where they looked at MR scans in temporomandibular joints in both asymptomatic and symptomatic volunteers that were not patients. And they did a prospective 15-year follow-up. So they found TMJ displacement in 31% of asymptomatic and 89% of symptomatic volunteers. So displacement is more common in symptomatic volunteers. And in 15-year follow-up, they saw unilateral progression in 3 asymptomatic and 1 symptomatic volunteer. But what they found, even though they could see these changes, in a 15-year follow-up, they had no significant change in the patient's symptoms. So, the bottom line is that TMJ disease is common. As I said, I heard that it was 11% of the world population has symptomatic temporomandibular joint disease. But the bottom line over time is that there's really not a lot medically that we can do about it, which is, I think, one of the reasons why MR is not as popular as it was at one time, because once you get the information, you don't quite know what to do about it.
What sort of things have they done in the past?
What sort of things have they done? They've done different kinds of surgeries to try to change the bony configuration. They've tried to suture the disc back in place, and that hasn't worked. There have been, I think, a number of prostheses that have been tried that have not functioned well. So if you have acute trauma, then occasionally they will go in and try to fix it so that it heals properly.
Why they wire the jaw, and so that you can't open your mouth. That's one way to treat the fractures. Another way is a surgical procedure, but most times they don't do surgery on the jaw unless it's markedly displaced. This orthodontal surgeons do a pretty good job of wiring and healing. So you go around with you eat with a straw.
Yeah. Okay.
Night splints are the most popular way to treat TMJ disease.
Oh, I forgot about that. Good. I'm glad you brought that up, John.
I use one myself, so
Yeah.
and no pain.
A lot of people actually recommend for everyone to have so-called night splints, which are basically relatively little plastic blocks you put in your mouth to keep you from clenching at night. And in fact, I think most dentists pretty much recommend it for everyone. It also protects the teeth themselves. So when you get John to my age, they are more protected over the years because you get little microfractures in the dentine of the teeth, which eventually can cause the teeth to fracture. And a lot of it is clenching at night when you're asleep, so it's hard to control.
Nightmares and dreams and so on.
Yeah. All right. Well, why don't we stop here for temporomandibular joint, and then if you want, I could give start another lecture on